Good morning. I guess it's almost afternoon. I've been working on this PowerPoint for quite some time now, so you'll have to excuse my time here. I cannot find the original PowerPoint that I did. I'm having a lot of struggles with that, but I'm working through it. So I just wanted to let you know for those of you who did not come to class or who would like to review this PowerPoint again, I have this option, and that if you did not attend class, please note on the review day you will have to turn in a study guide with notes on it, not just with the slides, but they have to have some notes. I don't care if you do screenshots of it. I don't care if you just send me the PowerPoint with your own notes on it. It's fine. You will be emailing me that information, and I will send out an announcement about it. So we will start the review now. Remember the Oh, wow. Moved it to the next slide without me even asking it to. So please remember that I actually made a mistake on this top one. It is all the things on the slide are important, but only what's in basically in the last two highlighted areas are what you need to know, where you don't need to know who it was. Ellen Church, who was the first female flight attendant, but you don't need to know the year that she was flying. She made an impact on flight attendant requirements that lasted till World War II. And she actually influenced the airline companies to implement a plan that required all flight attendants to be registered nurses. So, whenever World War II began, and we'll talk a little bit more about this in the next slide, she, the majority of the nurses who enlisted to help out in the war, whether it was stateside or whether it was in the European theater, so the airlines dropped the requirement for the airlines to be registered nurses so that they could actually find workers. Okay, slide number 3. The winged Air Force Rangers of the USA Air Force nurses. And the reason, following up what we did on the first slide, the reason that the nurses in World War II, the flight nurses started then, or the air evacuation, as it's called, if you remember, even Lori Maley talked about that's part of why their name was air evac for air evacuation. Then that's what it was originally called, was air evacuation, rather than flight nursing. The U.S. military, the planes weren't up to what they are now. They didn't have the ability to get onto into like heavy duty combat zones where it might be a lot of buildings. It might be that there were a lot of that it wasn't suitable to land, like a mountainous area, that sort of thing. So until the technology got caught up a little bit with the times, it was revolutionized during World War II. The medical care during evacuation was very efficient, and you'll see that whenever we go forward in this slide. So you definitely need to know that it was because the military wasn't properly equipped because of technology. And the commercial airlines, that's when they dropped the requirement for, but they did use the flight attendants as a model for the military nurses because they actually had a lot of knowledge. The original flight attendants had to know a lot about people being sick, taking care of people on long flights, etc. The program on the last bullet point program had to be volunteer based, which is something that a lot of people didn't know, when they may know that's how flight nursing started, but the reason it was voluntary, they weren't paid. They were totally volunteers. The flight nurses working for evacuating the soldiers that were injured, because the transport that they used had to be double duty. They used them for cargo planes and for military air evacuation for soldiers. And because they did not have the Red Cross in it, which is the Geneva Red Cross, which is where the International Red Cross is located in Geneva, Switzerland. And that they were in danger every flight. So that's an interesting factor, and I do want you to know that. All right. The next one, um, there's some interesting information on this slide. You don't won't have to know it for the test, but they talk about how the squadrons trained and things like that. But the most interesting part of it, and the part that you need to know, is in the last bullet point about the difficulty caring for these patients. I mean, the nurses had to be in top physical condition, and they did regular physical training and they participated in drill maneuvers. So just need to know that. Very important. Okay. And the despite the women filling roles in the military, nurses were the only females that were allowed in combat zones. Flight nurses, um, their duty location could change from the front lines to the nearest military hospital, and it could even be that could be cross-continental flights even, or cross oceanic flights, getting people home from hospitals in Europe into stateside. And that's also um, just goes back to uh, the nurses when they originally saw um, you know, saw the need for them, and it wasn't just on in the combat field, but it was far beyond that. And basically just talks about the things that nurses did and how they were. But what I want you to know also is that an FYI, that an evacuation plane could be airborne, loaded and airborne within 10 minutes, usually one flight nurse and one medical technician, and a flight surgeon briefed each nurse on board with patient's condition prior to takeoff. During the flight, she was responsible for the patient's safety. So if you remember when Lori Maley was here, it was Lori Maley talked about from landing to takeoff. Typically, flight wise, they want to be within 7 minutes. So it's pretty close to then. And I'm sorry, I may have to go back. It flipped automatically. This is very disturbing to me. This is absolutely on the test on slide 5. We're on slide 5 right now. Back to it. 500 U.S. Army nurses served for the medical evacuation team. Okay. So there were 31 squadrons. That's not important, but there were 500 U.S. Army nurses, and of those, one was held as prisoner of war, and 17 lost their lives in service to the country. And additionally, the last bullet point, it was of the nearly 1.2 million patients that were evacuated during the war, only 46 died en route. So it's thankfully, a very low number. So I just wanted to go over the last point on this slide, that when you look at the number of only 46 patients out of 1.2 million patients died en route, the flight nurses, the Army nurses did an amazing job, as well as their team. All right, the next slide. Okay, next slide. Okay, the Air Evac Life Team video from Lori Maley. And if you hear the number 46, that is familiar, but this is 46 million Americans live in rural communities more than 1 hour away from a level 1 or level 2 trauma center. Rural, I don't know why it's doing that. I'm really sorry. I so apologize. It's just moving things back and forth on my screen. I'm going to leave the pointer on it. It's very upsetting. This whole thing has not been fun today, so I apologize once again. So 46 million Americans live in rural areas more than 1 hour from a level 1 or level 2 trauma center. Also, don't forget, rural trauma victims are twice as likely to die from an accident or medical condition than urban victims or big city victims. The Air Evac was founded, and this is a need to know question. It was founded by a group of community members. It wasn't founded by the state or the city. It was just members of the community who wanted to improve the emergency health care in their community, and especially the community all around their region in the Ozarks, in the mountains. If you've been in the mountains ever, you can't get anywhere very fast. A lot of times you might have to take a detour, that sort of thing. So that's important to know. Critical access hospitals. The designation, the two things that you need to know are the two, number 1 and 2. I even put that in there on the slide so that you would know that those are specifically two. The question would be, for Medicare and Medicaid services, the designation given to rural hospitals. Number 1 It reduces the financial vulnerability. And number two, it improves access to health care, where we say access to care and know what that means. It's a shortened version by keeping essential services in rural communities. I mentioned this in class. Like small hospitals might be able to have a CT scanner, and they may or may not, but a lot of the small critical access hospital in our area has an MRI machine, as well as a CT scanner. And so we're very blessed to have that type of technology in such a small community. And it's because of the critical access designation. They get additional funding, they get breaks in pricing, that sort of thing. The government helps out with. Critical access hospitals also, it has several criteria, but because they aren't so important to me, just these are just the most important part is that the hospital has to have 25 or fewer acute care inpatient beds. Acute care does not mean ICU beds. It means just traditional hospital bed. If you're sick enough to spend the night or stay over, then that is acute, considered an acute care facility. So also they have to be able to have an emergency room that's open 24/7, 365 days a year. The other pieces are also requirements, but for this test, that's not important for you to know. All right. Trauma centers. Trauma centers, levels, categories, designations, and verification. So the first three bullet points are mostly important that you know there are five levels of trauma centers, okay? And then that the number one's the highest because students do forget and they think number five's the highest because number five's the highest number. For some reason, a lot of students space out and can't remember that. So hopefully you will notice that this will be a matching question. So you need to know where to put what. It will be it will have I'll give you two helpers on this one, the highest and the lowest level of trauma care, but just make sure you remember that level one's the highest and level five is the lowest because it will show the actual definition on the page. So I appreciate that, you making sure that you know that. All right, the next thing is the golden hour, absolutely important. We've talked about it a little bit before, but remember this, getting the trauma patient to definitive care within 1 hour of the injury for the best chance of survival. That means from the start of the injury to the definitive care means the highest level of care they need. So if they have to stop at a critical access hospital first, then they got to be at a level one trauma center. Then they need to be there within an hour. It doesn't change because they stopped at a critical access hospital. It just needs that they need to get rolling and get them out of here. So if you know someone needs to go, they'll skip the closest hospital and send them to the best hospital. That's a decision that's always made. Rural trauma victims, we said earlier, are twice as likely to die or 2 times as likely to die. It could be written that way. So twice equals 2 times. Because could be 4 times, it could be 5 times. You might see that in a question. So, all right, next slide. Definitions. The personal health literacy, that definition is pretty easy because it talks about individuals. So you know on the personal health literacy, it's the individuals have the ability to find, understand, and use information and services to inform health-related decisions and actions for themselves and for others. Organizational health literacy, it is the degree to which organizations, key word here in the definition, equitably enable individuals to find, understand, and use information for services to inform health-related decisions and actions for themselves and others. At the end, they're the very same if you notice that, but the organizations and individuals are in the beginning, so that should help you. All right. Guess what? Slide number 13, put a big X, marks the spot across it. X it out. We're not going to worry about that particular slide. And we're going to go on to slide 14. So you can literally put an X across it if that's how you're taking your notes and submit your notes that way. Okay. You will need to know this National Action Plan is based upon two core principles. Number one, all people have the right to health information that helps them make informed decisions, and health services should be delivered in ways that are easy to understand and that improve health, longevity, and quality of life. Slide number 15. 20 people, healthy people 2020, 2030. I'm sorry, I'm so used to saying 2020. Healthy people 2030 vision and mission. Vision for is the most important thing. I'd like for you to just, be familiar with the mission, but vision is what we're going to focus on. Is a society in which all people can achieve their full potential for health and well-being across the lifespan. All right. So that is, and then just have a good understanding of mission, but vision will be something that we would be looking for on the test. Healthy People 2030 goals. You need to know it. It's a 10-year plan. Every healthy people is 10 years. You don't need to know the second bullet point. I mean, just take that out. It's not necessarily that important. Um, Increased focus on health equity, social determinants of health and health literacy, and it has a new focus on well-being. So just know that that's what we'll be wanting you to know for the test. And then lastly is that Healthy People 2030 addresses the latest, excuse me, I'm sorry, I've got to take it back. I don't know what happened again. On slide number 17, it addresses the latest public health priorities and challenges. Like I stated in class, that this was like, for instance, a perfect example was COVID-19. I mean, that was a huge challenge. That was a ongoing at the beginning of Healthy People 2020. Slide number 18, Healthy People 2030 progress. So, I believe that I also X this one out, even though it's got a lot of information in it. It's not going to be, I was going to take it off and I did not. So please X out slide number 9. Oh, sorry. I don't know why it moved. I'm not really sure. I didn't hit anything that said next slide. I've got my pointer in one spot. I'm not sure what's going on. Okay, so basically just X out the slide number 18. Thank you very much. And we're going to go to slide 19, which is Henrietta Lacks and HeLa cells. And I'm going to want you to know a lot on those. Okay, Henrietta Lacks, as you all, I hope you remember that she was a poor Black woman who was diagnosed with cervical cancer. Her cells were used for research without her family's consent or her consent. And when the surgeon took the tumor cells and when he was head of the tissue research at Johns Hopkins Medical Center, which is a major medical center in the United States and well respected, at that time it was really common for doctors and scientists to use patients' cells without their consent. And we'll talk a little bit more about this on the next slide. Also, you have to know bullet point number 3 is Henrietta's cells not only survived, but they multiplied really quickly at an extraordinary rate and were the first immortal cell line. Okay. And let's see, I think they not only survived, but I think maybe that's in, yeah. Anyway, they're still alive today. I'm not sure. Oh, still survive today. I see it. Sorry. It's been an interesting day in my life yesterday and today. The 21st century, Henrietta's case, this is just going back to what it said on the previous slide, that what happened with Henrietta Lacks was reason enough for the science community to see that they needed to have informed consent protocols of patients for the extraction and the use of cells in research, because people need to understand what people don't understand about informed consent. It is extremely important. Informed consent is extremely important, and it is something that has basically improved over the years as as they were learning about what worked and what didn't work, and it's had some changes made to it, but the protocols now are pretty well done. There's still some areas where people are looking to improve informed consent so that you really truly understand what is happening, whether it's surgery, whatever procedure, or whatever risk you might have, whether it's physically, psychologically, or socially. There are just all sorts of considerations that need to be given for certain informed consent. Um, you need to know that cells were used in over 75,000 studies. The video said 74,000, but it's up to 75,000 now. And I apologize about not having the period being, it's a period instead of a comma, it should be a comma. So 75,000. The cells were used to develop treatment for treatment or prevention of the following: polio, cancer, different, a lot of different types of cancer, diabetes, HIV/AIDS, and many other diseases and conditions. And then just the FYI, the last bullet point is just that in 2013, the National Institute, that was the year that they granted the Lax family control over how the HeLa genome would be used. So if they didn't want it used for a certain study or they had some ethical choice not to do that, they had that option, which I think is very great that they did that. Types of healthcare approaches, we're almost done. Yay. There's downstream. Oh gosh, I'm just like I said, I really apologize about that. I have no idea why that's happening, but the slides at the bottom are moving on this. I don't have it on AI, but it's sort of like it's doing that. I'm not sure. Um, anyhow, downstream thinking. You think about being downstream. If you're downstream and you're trying to paddle upstream, it's really difficult and it takes a long time. If you were going from upstream to downstream, the current, you're with the current instead of going against the current with downstream. So the upstream thinking is where society is the focus of change. It's a macroscopic approach. And downstream thinking is where the individual is the focus of change or microscopic. So if you think individuals microscopic, it's one person, one is smaller than many. Upstream thinking macroscopic, it's a whole lot of people. I'm holding my hands out, you can't really see. So um, since I have to have my face on here. Let's see. And you need to know all those on the slide, everything on the slide you need to know. The levels of prevention. This is the last thing that we're going to talk about. And it's going to be, the question is going to go on between this page and the following page. The primary, there are three levels: primary, secondary, and tertiary. Primary, um, I have a chart coming up and it will have them labeled. The first choice, the first definition will be A and the second is going to be B on the chart. So I will read them as such. So in primary, uh, the first level of prevention of primary is, or example, is the prevention of problems before they occur, such as a vaccine. A vaccine can absolutely prevent something before it occurs. Health, excuse me, health promotion and health protection. Health promotion, health protection is basically teaching people by promoting healthy eating habits, healthy exercise habits, and or protecting your health in different ways, like wearing bicycle helmets, putting children in car seats. There's lots of different examples of it. Uh, excuse me, and having them properly fitted for their age and stage and weight. Secondary, early detection and intervention. And the early detection means that you've had, by early detection, typically you find something by screening. Most of the time, routine screening, such an example would be a mammogram. You could find breast cancer, and intervention is going to be something of the effect like surgery to remove, basically, it stops they find it, intervene, and they're able to stop the disease at that point. Early diagnosis and treatment. It could be that a diabetic is taught how to use insulin, and they find them young, or excuse me, I don't want to say early in the disease process, and they treat them. Also, uh, oh, excuse me. Someone who has, let's see, early diagnosis. could be, I'm thinking, hang on just a minute, let me make sure I'm going to say this correctly. On the secondary. Yeah. Okay. I was pretty sure I was in that column. I just didn't want to have anything that did not meet with that. Um, Early diagnosis and treatment also could be a man has a prostate screening, and he literally goes to the doctor, has an exam, and they feel something, because it can be enlarged. And if you continue nursing school, you'll actually do those exams on a model. It'll be a model, but you'll actually do those, and they're very interesting. You'll also the treatment for that. There could be multiple methods of treatment. It could be a chemo pill. It could be if they have prostate cancer. It could be the radioactive seed beads. They call them seeds, and it could be removal of the prostate. There are also other for BPH where it's benign hypertrophic BP. I have to let's see. BPH, benign prostate, what BPH? Oh, like I said, excuse my brain today. It's not working very well. I've been up too long and too much to have to manage today. So, tertiary correction and prevention of deterioration of a disease state, and that would be A. And then B would be limitation of disability and rehabilitation. So, the correction and prevention of deterioration of a state would be an example would be a woman having a mastectomy if she has diagnosed with left breast cancer, and they remove the left breast and then you've stopped it. And some women may opt for both breasts, and that you could also consider that as tertiary. The limitation of disease and disability would be rehabilitation following a stroke, and many times that would things that could be involved could be physical therapy, occupational therapy. Occupational therapy works from basically the waist up. Physical therapy, they always say that like eating with your hands, that sort of thing, like being able to perform different tasks. And physical therapy, occupational therapy, and speech therapy for a stroke patient. Cardiac rehab is another that could be the stent placement. That actually would be, um, excuse me, that would be uh, correction and prevention. So you would correct the blockage by opening up the stent. It's like a little, kind of like a little, not really like an umbrella, but sort of works that way. It opens up and it allows blood to pass through and opens the artery back up, and the diseased area around the artery, typically they remove the plaque, and open up the artery, and there the person is getting back to normal because it prevented the worsening of that and deterioration. So they correct it. So you had normal blood flow, and then the disease process should stop at that point. Next slide is our next to last slide. Now, this I'm just going to tell you is actually going to be on the test almost like it is. The difference will be, and you can see A and B, and if you look at over here at the under primary, you see the first two are levels of prevention of problems before they occur. The second two are B, which are health promotion and health protection. And you see the secondary the same way, AA and then BB. And lastly, I know you might not be able to see it because my face is on there, but it's also AA and then BB. So if you just count down, you can know the first two are AA and the last two are BB. On the test, it's going to be a chart. It's going to have the definitions at the top, like everything above the word levels of prevention practice are going to be there. Okay. And so is the primary, secondary, and tertiary, and then the definitions, the A's and B's are going to be up there. So you should be able to figure out what belongs where. There will be 6 answers. Um, let's see, wait a minute. 8, let's see, 2, 4, 6. Yeah, 6 answers because there's 3 different levels of prevention. And I'm just going to show one example of each A and B for each one. So it'll be one example of primary prevention A, one example of primary prevention B. I'll mix them up on here. And then one example of secondary prevention A, one example of secondary prevention B, same way. One example of tertiary prevention, excuse me, and for A and one for B. So hopefully you can figure it out. I mean, I don't think it'll be too hard, but like I said, they'll be mixed up. I will put a little bit of direction. Please mark the correct level. You could check mark it or X or whatever, and then put whether it's A or B. So I will have directions on the very top telling you what to do. So you know what the question is going to be. So just make sure you know what the answers are. Okay, lastly, yay, we're done. Yay. So happy because I've had to make this. This is the sixth try. That's why I'm rather over it. But I wanted to get it done for you because I just thought it was important that those people who didn't come, since we're going to give credit from now on, we're going to start giving credit for attending the day of review, and your 10 points will just be based on your attendance. Exam 2 itself is worth 50 points. Test will be on paper. There will be 25 to 30 questions, possibly because I've added that one. It just depends on how they work out. There will be, it might be less, it won't be any more though. Feel pretty certain about that. The true false questions will be worth 1 point. Maybe a fill in the blank if it only has two choices, that might be worth only 1 point as well. Multiple choice and select all that apply and fill the blank depending upon how many choices they have will be 1 or 2 points. Let's see. And I think, oh yes, there will be a choice. I forgot to read that on there. There will be a choice selection. So literally below the question, you'll have a choice of like A, B, and C or A and B for fill in the blank. So you don't have to write the words. So get some rest. I need to take the same advice for myself. And remember to your study guide or your study and test taking steps and I tips. Let me just start all over again on that one. Get some rest and remember your study and test taking tips. That's too many T's in there. All the best on the test. And I hope that y'all have a good day. And sorry I was a little discombobulated. I have been like on a mission. I've just had like, it's been crazy. And someday I'll tell you my crazy story about my cell phone. Yes, that someone stole and we found it. So yay. It's a happy day. At least I got it back. Sadly, it was dead though, and they had killed it with some sort of hammering type device. So everybody have a great day, and we will see you hopefully tomorrow. There will be an opportunity for a makeup test should you miss the class on Thursday. The original plan I have is for Tuesday at 8 a.m. So if you're going to have to miss the test and have not already notified me, please do so. And I hope to see you then if you can't come tomorrow on Tuesday, the this following Tuesday. I'm not sure the exact date because I haven't even looked at the calendar today. So have a great day again, and I will see you tomorrow.